Hello and welcome to WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio Menard. Parents understand that conditions affecting their child's kidneys, bladder, or reproductive health are not just the standard childhood illnesses. These conditions can affect a child's life into adulthood. Today, we're talking with Dr. Osama Al-Omar, Chief of Pediatric Urology at WVU Medicine Children. Pediatric Urology at WVU Medicine Children is the only pediatric urology practice in West Virginia, and it has been recognized nationally by U.S. News and World Report several times. Welcome, Dr. Al-Omar.
Mary, glad to be here and thank you for having me.
Okay, great. If you have any pediatric urology questions for Dr. Al-Omar, just post them in the comment section below and we'll try to answer them live. Okay, we got a lot of ground to cover here today.
Very good.
As we mentioned, the WVU Pediatric Urology program is the only one in the state, so you see it all. So what are the most common conditions you see and treat?
So pediatric urology is a subspecialty that deal with babies through first day of life until age of 18. So most of the things that we see most commonly, they are around the congenital anomalies. And the most common ones are undescended testicle, hernia, hydrocele, and we also see a lot of dysfunctional voiding, bedwetting, kidney stones, and other congenital anomalies that affect the kidney.
There's a lot that can go wrong,
Yep.
huh? Okay, well, let's talk about some of these common conditions. Let's start with undescended testicles. It's actually a pretty common condition, isn't it?
Yep. About in premature babies up to 30-40%, and in full term drop down to about 1 to 3%.
So what exactly is undescended testicle?
Undescended testicle is a terminology describe that the testicle is not reaching its final position in the scrotum. So as we know, the testicle formed during fetal life just below the kidney and it's inside the abdomen. And then it follows a certain pathway guided by hormonals, certain hormones, through the inguinal canal, through all the way down to the scrotum. So if the testicle stop at any position in this pathway, we call it undescended testicle.
Okay, so are you supposed to be born that way? Should they already be where they're supposed to be, or does that happen later?
So the testicle reaches its final position around birth. So as I said, at full term, about only 1 to 3% of children, boys, they have undescended testicle. While the premature, because they did not complete their fetal life in utero, so they have higher, and then with more maturity, the testicle reach the final position in the scrotum.
So how do you treat that?
So it actually depends on where is the testicle. So initially, in the first 6 months, we observe the undescended testicle because there's about 50% chance for a testicle, especially if it is in the inguinal canal or suprascrotal, to descend and naturally. So you don't need to do anything. However, after 6 months, that's chance of descending spontaneously goes down almost to zero. So at this point, we go ahead and do surgery, because if we left the testicle not in a normal position, then there's consequences for that. And according to our society, American Urological Association, the golden period to do the orchiopexy, we call this procedure orchiopexy, is between 6 months of age and 18 months of age. If the testicle is very high inside the abdomen, actually we do something called diagnostic laparoscopic, which is diagnostic and therapeutic, where we go with a little telescope and free the testicle whether in one stage or in 2 stages. And we free it and bring it down to the scrotum. If the testicle is palpable in the inguinal canal or suprascrotal, we make a small inguinal incision and we free it, and then we position it in the scrotum and fix it in that place so it does not bounce back up to the groin area.
So should I be concerned if my son has this condition?
Yes, I think it's very important to understand that the normal position of testicle in the scrotum is very important for the testicle to grow, number one. Number two, to function normally. And any normal testicle normally has two functions. There's hormonal function and there's reproductive function, meaning producing sperms. So for the testicle to function normally, it has to be in the scrotum. That's one aspect. The second aspect is the testicle has risk if it is not in the scrotum for malignancy. That risk, I'm not going to scare families, because fortunately that risk, if we address the undescended testicle, will drop down from what we call odd ratio from 8 times to 2.2 or 2.3. So it significantly goes down if the surgery is done. Yes, is done before puberty. Third thing is undescended testicle, unfortunately, has high risk for testicular torsion. So it's something, testicular torsion is when the testicle turns around its axis, so it cuts supply to the testicle, blood supply to the testicle, and that will leave the testicle without blood supply and causing necrosis.
Oh, my.
So there's about 20-25% risk for testicular torsion. And finally, from cosmetic perspective, a scrotum should look like two testicles in right and left. So it's really important to address this issue on a timely fashion.
Okay. Sooner than later.
Correct.
Right. Okay. You mentioned also that dysfunctional voiding is a common ailment. So what exactly is that?
So dysfunctional voiding is actually very common medical problems that we see in our clinics. In some statistics, it's actually up to 10 to 15% of pediatric urology clinic visits are dysfunctional voiders. And for that, in any academic institution, there's always a program tailored to address those issues, because they need a lot of time to discuss what's going on with the child, with the family, and address their problems. It's a terminology to describe the abnormalities in the proper function of the bladder. And the bladder normally has, the normal function to the bladder is to store the urine in a normal way until it's appropriate in terms of time and place to go and urinate, which is what we call the voiding phase.
Okay.
So we have a storage phase and we have voiding phase. If there's any abnormalities in the storing phase, which, like for instance, urgency, frequency, that's what we call the storage phase. We call it dysfunctional voiding. The same apply for voiding phase. If there's like weak stream, if there's infrequent voiders, that's also an issue described as dysfunctional voiding.
Okay, so when should a parent call their doctor about this?
So that's a very good question, actually. So typically when dysfunctional voiding start affecting the quality of life for the child and for the parents, then they call the doctor and take an appointment. Give you example how it affects the child, for instance, like the family receive calls from teachers saying that your child is every 5 or 10 minutes or 15 minutes want to go to the bathroom, or an accident happened during school time, or they are traveling, let's say traveling 2 to 3 hours, and the child demanding the family to stop and rest area every 15, 30 minutes. That's how we know about it, or the family know about it. So I would say, as I said, it's when it's affecting the quality of the child or quality of life for child or the family.
So how do you treat that?
Very good question as well. So dysfunctional voiding, fortunately, is something very treatable, especially with education. So the first step for treatment is to understand exactly what type of dysfunctional voiding affecting the child. Is it storage problem, frequency, urgency, or it is voiding problem? And then we the first step, initiate what we call urotherapy. Urotherapy, it's describing instructions and proper dietary and voiding habits. Talking about dietary habits, we instruct family to give enough amount of fluids, and mainly water and fluids that does not irritate the bladder. There's known fluids to irritate the bladder, like caffeinated fluids, soda. So we instruct them to decrease it. Just be mindful what they are drinking during the day. The second thing is regarding voiding. We instruct them, children like to play and get distracted. So they, let's say, play games or watching TVs, they get distracted and they don't go on time to the bathroom. And then all of a sudden they do the pee dance. They rush to the bathroom. So we tell them they need to instruct children to go normally every 3 to 4 hours, and in some situations, every 2 to 3 hours. Finally, which is very important, goes with dysfunctional voiding, is treating constipation. Constipation is really very associated pathology with dysfunctional voiding because they share the same pathway in the neural system. So I describe it to family. It's like you have a highway where there's like 2 or 3 lanes. And if there's an accident on one lane or congestion, that's lead to congestion on the other lane. So it's really important to understand whether the child has constipation. If there's constipation, then we treat constipation with fluids, fibers, and stool softeners.
Okay. Okay, another common problem, bedwetting. How do you treat bedwetting?
Okay, very good. Just from statistics standpoint, at age 5, about 15% of children, they have bedwetting. So it's really, yes, very, very common. I just want to say, in general, primary bedwetting, there's primary and there's secondary. Primary when the child never outgrow the bedwetting or having accidents overnight. And the secondary is when they have a period of 6 months dry overnight, they don't have accidents after achieving dryness overnight, then they have accidents. So the primary one, the majority of them, they are part of the maturation, whether there's a delay or not, but it's part of their maturation in the neural system that communicate between the brain and the bladder. So how we treat it, we provide education to the family about causes of the bedwetting, and we instruct them to do the same urotherapy with some modifications we call behavioral modifications. In addition to the type of fluids they are drinking, the children they drink, we try to shift the fluids to like early morning to noon, exactly earlier in the day, rather than at the end of the day. We try to eliminate also any bladder irritant fluids or diet after like 2 p.m. or 3 p.m., such as coffee, tea, soda. We also try to eliminate sugary high fructose drinks after evening time because it causes diuresis and cause bedwetting as well. Last thing we tell them, that's for the urotherapy, we tell them to stop fluids 1 to 2 hours before bedtime and have the last trip to the bathroom to empty the bladder just before bedtime. There's improvement. This is very essential because about 20 to 30% of children, just in starting this urotherapy, they will have great improvement or cure from bedwetting. Then it's also important when we start talking about medication. So if it doesn't work, then we start giving medications, and there's different medication we can give. The most important one called antidiuretic hormone, ADH, it's called DDAVB. And we start this medicine about like 3 to 4 months, at least up to 6 months. It's highly successful. There's also a behavioral learning with a little device called alarm device, where it's like a small device that sense the wetting, whether in the underwear or on the bed sheet, and send vibration and
Like wakes them up.
Exactly, an alarm that wakes up the child and the family take the child to the bathroom to urinate. Time after times, in 2 to 3 weeks, the child will wake up before the alarm goes off and the wetting happen. And
a lot of different ways to treat
there's
this.
Different ways to treat it.
What's the best way for a parent to help their child deal with bedwetting? There's such a stigma.
Exactly. So I would say education is very important. Education about how common is the problem, so they don't feel embarrassed. I always tell families, your child doesn't know, like at age 6, 7, that about maybe 10%, as I said, at age 5, 15%, and every year that certain percentage of the 15% outgrow the problem. By age 15, only 1% of the population has bedwetting. So education is very important, so they don't feel embarrassed. The second thing is provides emotional support for them, reward them actually for dry nights. And I stress very important thing is not to punish them for the wet nights. It's really negative reinforcement never works, so it's really is not going to work. And pay attention to their diets and drinks, and try to stick to the instruction that we already spoke about.
Okay. Now, what about kidney stones? Can kids get kidney stones?
Yes.
Okay. So how can you tell?
Yeah.
How do you know if your kid has a kidney stone?
So very good question as well. Kids like adults, they get kidney stones, but not as much as adults. But unfortunately, in the last 20 years, in Western countries, the incidence of kidney stone is being increased year after year. Like adult, the kidney stones cause pain, and the pain typically in the flank area and radiate down to the genitalia or to the groin area. Pain also associated with nausea and vomiting sometimes. Sometimes kids describe his or her urine as bloody because it causes also hematuria or bleeding in the urine.
Oh, wow,
A rare situation with when the stone is actually impacted, meaning it's stuck in the ureter and block the ureter, it may cause also infection. That's like not the norm, but it's serious at this point.
So how do you treat kidney stones in kids?
Very good. So again, dietary modification. So when we talk about kidney stones for families, we tell them there's two important steps in the treatment. The first step is to eliminate the stone from the urinary tract system. And once we do that, we get the fragment from the stone to analyze it. And we do, working with our colleagues in nephrology, pediatric nephrology, we do what we call metabolic workup to see the risk for kidney stones, what we call preventative workup. So the first stage is eliminating the stone, and the second stage is a preventative workup to decrease the risk in the future to form another stone. For the eliminating stones, we have different tools. We can observe the children to pass the stone spontaneously, and luckily they have higher success rate for passing stones compared to adult patients. We can sometimes give them medicine that relax the ureter, the tube that connect between the kidney and the bladder, and help passing the stone, called Flomax tamsulosin. Second thing, if not passing the stone and the stone causing symptomatic, causing pain and other issues, we can actually do surgery. And surgery, based on the location, based on the size of the stone, could be they are all minimum invasive.
Oh, that's good.
Yeah, it's rarely or I personally have not done any open surgery for kidney stone.
Stone.
So there's something called shockwave lithotripsy. where the child under sedation, and then there's like little device that generate waves that travel through the body tissue to the stone and blast it into small pieces.
Breaks it up.
Exactly, and then
Pass
the child pass it. But with advance of technology, now we have better tools that eliminate the stone right at the time of the surgery. We call it ureteroscopy. It's like a tiny scope that is literally like 1.5 to 2 millimeter in diameter that goes through the pee hole, urethra, backward, all the way to the ureter, to the kidney, where is the stone, whether in the ureter or the kidney. And we use a technology called holmium laser, which is help to dust the stone, make it like really dust, or fragment it, or make it pieces, and then we extract the pieces at the time. So there's no pieces for the child to pass, and there's no pain associated with it.
Like a vacuum.
Exactly. And if the stone is really large, we are talking about 2 centimeters or more, we can do something called PCNL, percutaneous nephrolithotripsy or lithotomy. It's the same principle. A scope goes through the back directly to the kidney. After we dilate that track up to like 1 centimeter, sometimes there's a micro PCNL, smaller size, and we pass the same instrument scope and laser, or sometimes lithoclast. It's like a machine, special machine that actually blasts the stone and suck it, and like a vacuum, exactly what you said.
Okay.
We use this technology, and sometimes we combine both. Shockwave with ureteroscopy or shockwave with PCNL.
So a lot of different options there.
Then I just want to finish this. Then we move after that to the preventative workup, where our colleagues from nephrology look at the stone analysis, do blood tests, urine tests called 24-hour urine collection, and assess their risk. If there's something they can change in their diet or they can give them medicine, then they will do, and that will decrease their risk for stone formation in the future, which is better than treating the stone.
Okay. I want to talk about telehealth because it's really important. You know, here in West Virginia, we're in such a rural area. Telehealth options are really important. So what kind of pediatric urology conditions can you take care of through a telehealth visit?
So first of all, we are very proud here at WVU Children's Medicine of our telehealth program, Pediatric Urology telehealth program, and we are one of the leaders in the telehealth program in Children's Hospital. So in general, almost everything can be seen as a telehealth in pediatric urology. I would say telehealth is, I feel like it's created for pediatric urology. And our state is a rural state, so it's also fit our state. So I'm very proud of this program. And so talking about what cases, the same. Undescended testicle, hypospadias, congenital anomalies, redundant foreskin, dysfunctional voiding, bedwetting, UTIs. Very much we can see everything. Historically, telehealth used to be for post-operative visits. We at WVU, we advanced this, and we are not only seeing post-operative visits. We are seeing post-operative visits. We are seeing diagnosis, like I mentioned, and treating them through the telehealth. And we are actually seeing surgical cases booked through the telehealth.
Wow.
Yep.
Wow. Now I know your pediatric urology practice. It's the only one in the state that offers robotic surgery.
Yes, indeed.
And really, robotic surgery can be used to treat just about most of the conditions we've been talking about today, right?
Correct. To be specific, robotic surgery is used to treat any traditional abdominal open surgery.
Okay.
Then we move into laparoscopic. So it's now replacing almost all the laparoscopic pediatric procedures. And it also fit ped urology, robotic surgery. Why? Because most of our congenital anomalies need reconstruction, suturing. And suturing with straight lap is challenging, has like very steep learning curve. That's prolonged the surgery itself. So we, with the use of the robot, it's like freehand. So
Oh,
yeah,
okay.
it's you have all the movement that you have in your hand. That help us to make the surgery shorter and as effective as it is open. So
And then you
very
have a quicker recovery usually,
quicker,
right?
yes. So the advantage of laparoscopic robotic, we call it robotic assisted laparoscopic procedure. The advantage of any laparoscopic robotic is shorter hospital stay, less pain, and faster recovery. So robotic achieve all of those.
Excellent. So before we go, because we're just about out of time, what's the most important thing you want parents to know about the WVU Pediatric Urology program?
Okay, so I want to say I am very proud of our program at WVU Pediatric Urology. And I'm proud also of our staff and all the people working with us, from front desk secretaries, schedulers, and nurses. Pediatric urology is around 24/7 for the people of and the families of West Virginia. We are a comprehensive service that provide everything from minimum invasive to bread and butter. We have the most advanced technology, as I said, robotic and holmium laser. And we have a very caring team. My mission and my division mission is we treat your child as if it's our child and part of the family. Nice. And I believe that there's nothing cannot be treated in the WVU Pediatric Urology division, and child should not travel out of the state to seek pediatric urology treatment.
All right. Well, thank you so much for sharing all this information with
so
us
much
today.
I enjoyed this show, and hopefully looking forward for another one in the future.
Sure. We enjoyed having you. Thank you so much. That brings us to the end of this edition of Tuesday Talks. If you're looking for more information on pediatric urology issues, you can always visit wvukids.com/urology. And join us for Tuesday Talks on December 20th, when we'll talk to Dr. Salim Abunaja from the WVU Medicine Medical and Surgical Weight Loss Center. I'm Mary Ravazio Menard, and on behalf of Dr. Al-Omar and everyone at WVU Medicine, thanks for joining us and have a great day.